Well, welcome back to chapter 42 and part 5 of Obstetrics. This is the last and final part for this chapter. It's a very lengthy chapter with lots and lots of information. We're going to start out with this chapter. We'll talk about high-risk pregnancies, and some of the things we need to be aware of, as well as, the treatment plans that we may need to implement depending on the particular situation. Then we'll talk about some pregnancy complications during pregnancy, complications postpartum or after pregnancy, and then we'll finish up talking about trauma in pregnancy and how traumatic events or being involved in trauma is going to impact someone that is pregnant. All right, with that, let's go ahead and get started talking about some high-risk pregnancy considerations. The first one we're going to look at is precipitous labor and birth. This usually means that the newborn has been delivered prior to us arriving at the scene. The entire labor time and birth time usually lasts less than 3 hours, so it's usually a very quick process. This is not common in women who are pregnant for the first time, and the chances increase with the more children that that particular mom has had. If the patient's had prior precipitous labors, be prepared for it to happen again. So contractions usually are more intense and much more effective in these because it gets things moving along pretty fast. You want to assess the patient post-delivery for tears and bleeding and manage those as needed. And there are usually a few adverse effects with these. Sometimes the newborn might have some facial bruising, and they might have a oddly or a somewhat misshapen head. Nothing really major to write home about, but those are some of the things that we might see that with that abrupt, rapid birth because it's less controlled, by having somebody trained there to help them through it. Post-term pregnancy babies, what happens with these is these are babies that are born after the 42nd week, so they're past the normal gestation period. The cause of these is typically unknown. It is considered high risk because the baby may become malnourished due to the placenta trying to go ahead and detach from the uterine wall and the baby receiving less nourishment. There's also a much greater increased chance of meconium aspiration, which we'll talk about here a little bit later. Risk factors for this include previous post-term pregnancies, irregular menstrual cycles, which usually increases the chance of miscalculating due dates. This condition increases the risk for longer labor and complicated delivery. It is usually recommended that the delivery be done by cesarean section in these cases when this happens. So oftentimes we don't see this, but sometimes we'll see it where we're getting called for these, because things have went on a little bit too long, or there may be an interfacility transfer where we're dealing with something like this. Not typically an emergency call that we see. Meconium staining, this is when the baby passively ingests elements while in utero, such as mucus and amniotic fluid. This winds up becoming the first stool, which is called meconium, that the baby passes. It's odorless, a greenish black color, and has kind of like a tarry-like consistency. It's sterile. In cases of fetal distress or stress during birth and delivery, meconium may be voided into the amniotic fluid. So the baby may discharge this meconium into the amniotic fluid. This can actually result in chemical pneumonia in the newborn if that fluid is then inhaled into the lungs. Umbilical cord prolapse can also contribute to this potentially happening as well. So in those instances where we have umbilical cord prolapse or a long or stressful delivery, the likelihood of there being meconium staining begins to increase. Meconium in the amniotic fluid is only detectable once the water breaks, and what you'll see is a yellowish tint, and that's going to suggest that meconium has been released into the amniotic fluid and it's been there for a little while. A greenish black color suggests that it's more recent, which is a sign of much greater danger. If meconium staining is present and the newborn is not responding normally, initiate ventilation and non-rebreathing, and make sure that we effectively provide resuscitation for those newborns. We'll begin to follow that normal neonatal resuscitation protocol, which is going to include warming, ventilation, and oxygenation. And we always want to make sure that the airway is not obstructed, so we want to do a really good job of suctioning that airway with the bulb syringe. If the newborn is moving vigorously and appears to be breathing adequately, suctioning is generally not recommended with these newborns. However, we do need to make sure that we note that and advise the receiving hospital that there was meconium present. Even though suctioning wasn't done, it may be something that they want to watch out for, a little more long term. So fetal marcosomia, also referred to as large gestational age, describes a baby that is unusually large. These are typically babies weighing more than 4,500 grams or 9 pounds. And this is considered marcosomic. Risk factors for these large babies include gestational diabetes and poorly controlled pre-existing diabetes, excessive weight gain during pregnancy, maybe even a male fetus or a post-term pregnancy. If there's a higher number of previous pregnancies, that kind of raises the risk factors. Maternal obesity, and there's some genetic conditions about the fetus as well, or the baby as well, that may contribute to this happening. Treatment should focus on supporting the mother and providing rapid transport, as cesarean section is likely going to be needed for delivery. If in the event of a field delivery, it's helpful to encourage breastfeeding afterwards. So that will help kind of shrink down that uterus, because it's going to be a very large sized uterus. Help shrink that down and control bleeding. Check the newborn's blood glucose levels, because these larger infants are much more increased risk of hypoglycemia. So we want to make sure we check a glucose level in those shortly after they're born. When multiple babies are expected, be prepared for more than one resuscitation and be ready to call for additional resources if needed. Twins are generally smaller than single births, and delivery is usually not as difficult. Consider the possibility of multiple births if the firstborn is smaller than you would expect given the size of the mom. And then, of course, if the abdomen remains relatively large after delivery of the first baby, the second baby is typically born within 45 minutes of the first, with contractions usually starting about 10 minutes following the first one. So more than likely, after the first one is born, you're more than likely going to have time to go ahead and transport to the hospital. But be aware that it's possible that you may not. They may come pretty quickly after each other. The procedure for dealing with multiple gestation deliveries is essentially the same as a single birth. Cut the umbilical cord of the firstborn as soon as the delivery is complete. The second newborn may or may not deliver before the placenta of the first one. It kind of depends. When the placenta does deliver, you want to check and see if there are 2 cords coming out of that one placenta. If there's 2 cords coming out of that one placenta, then it's going to be identical twins. If there's only 1 cord, then that means that the twins will likely be fraternal and there will be 2 separate placentas. Record the time of the birth for each newborn and identify the newborn delivered as baby A. So it's important that you denote which one is which in some way or another. Intrauterine fetal death is not uncommon, and this occurs when the baby has died before the onset of labor. This condition affects only about 1% of all pregnancies. In these cases, the care provided will primarily focus on the mom's emotional and physical needs and not so much the baby's needs, because there's not much we can do. The cause of fetal death is typically very difficult to determine, but they believe it may be related to complications with the baby themselves, the placenta, or even the mother. So it could be any one of those 3 things that has resulted in fetal death. Risk factors are going to include things like infection, genetic disorders, poorly controlled diabetes, hypertension, preeclampsia, and eclampsia. Even that RH factor incompatibility can come into play here. And it is a higher risk when there's multiple gestations as well. Oftentimes, the mom can go into labor up to 2 weeks or more after the baby has died inside of them. In most cases, labor will progress normally. If the cause of death is an infection, there may be some foul odor noted with that. The fetus may also begin to show signs of decompensation or decompensation with the soft tissue and possibly formed head. May show signs of blisters and skin sloughing and dark discolorations. So just be prepared for that. Of course, with these in newborns or these infants, resuscitation is not appropriate because there's obvious signs of fetal death. It's important not to confuse fetal death with cases where the fetus is in cardiopulmonary arrest after or during the birthing process. So we're talking about babies that have died in utero and they've been in there for a little while, so much so that they've, their bodies are beginning to break down. That's not the same as a baby that goes into cardiac arrest during the birthing process. So it is possible, but extremely rare, for there to be an amniotic fluid embolism. And if this does happen, it is a life-threatening condition. Risk factors for this are going to be women over the age of 35 typically are more susceptible to this. If there's some eclampsia or abruptio placentae, placenta previa, uterine rupture, or even fetal distress, these would all be indications that we need to keep a close eye out for an amniotic fluid embolism with the mom. The mechanism for this fluid embolism is really going to involve this amniotic fluid, and fetal cells are basically going to enter the mom's pulmonary and circulatory system through the placenta via the umbilical veins. And this typically happens due to ruptured membranes or a ruptured cervical or uterine veins is how this is typically going to happen. The condition then triggers an allergic reaction from the mom's body, which leads to blood clotting, cardiac and respiratory collapse, and even death if not treated quickly. So realize that what we wind up with an amniotic fluid embolism is going to be very similar to an anaphylactic type reaction. So signs and symptoms are going to include sudden onset of respiratory distress and hypotension, cyanosis, maybe even seizures, cardiogenic shock and unresponsiveness will progress, and then fully on into cardiac arrest. This is a true medical emergency requiring immediate advanced intervention, so we got to act fast with these if we want to save the mom. If the patient survives the initial reaction to the amniotic fluid, she'll likely develop a blood clotting disorder, which can lead to severe complications such as internal bleeding. Treatment for amniotic fluid embolism is going to include supporting the respiratory and circulatory systems, and this may involve administering oxygen, giving mechanical ventilations, and even medications to stabilize the blood pressure and support the heart's function. It's really important to transport them rapidly to a medical facility with the necessary resources for maintaining the critical conditions of this patient. This patient is going to require advanced care that may not be available at every smaller hospital. So those hospitals that have surgical interventions and an OB department is going to be kind of the best bet for these types of patients. So there are some conditions where there's too much amniotic fluid, and this particular one is a condition where there's too much amniotic fluid around the baby. Polyhydramniosis, the causes for this can include things like carrying more than one baby, having multiple babies in there can cause an increase in amniotic fluid. There could be fetal anemia that can lead to an increased fluid production by the fetus. Diabetic pregnant patients can cause fetal abnormalities that affect this fluid imbalance. There could be some conditions with the baby as well, that things such as some esophageal conditions or some structural abnormalities that can prevent the fetus from being able to swallow the amniotic fluid, and this can lead to an overaccumulation of that fluid. Detection is often by early ultrasound, so most of these patients already know that they have this if they're receiving appropriate prenatal care. So it may or may not be a surprise, so the patient may report that they have this, although it may not always be known if they've not had good quality prenatal care. Of course, the risk factors to the mom and fetus are going to include things like a prolapsed cord or abruptio placenta. The extra fluid can cause the uterus to expand more than usual, which increases the risk of these complications actually occurring. There's going to also be an increased risk of postpartum hemorrhage, because the larger uterus may also result in excessive bleeding after delivery, because there's just more space, and it's going to be harder for that uterus to kind of contract and to cessate the bleeding that normally occurs after birth. So oligohydramnios is a condition where the volume of amniotic fluid is less than what is expected. The causes of this may include things like dehydration, where there's a lack of fluid in the body that can lead to a reduced amniotic fluid production, because the mom's body's trying to hang on to all the fluids that it can. There could be a premature rupture of the membranes or a leaking membrane. If the membranes break too early, the amniotic fluid may leak out before labor begins, and then we wind up with a condition where there's not enough fluid in there. And there could be there could be something that causes a decrease in production, like kidney problems in the fetus, that can lead to a decrease in fluid production. Diagnosis and treatment in the field, there's really no way for us to diagnose it in the field definitively. But if the patient has a history or signs of this, we need to transport her to a specialty care center for further evaluation and management, because she may wind up turning into a high-risk pregnancy. Now, don't automatically assume that we're dealing with pregnant moms that are on the verge of delivery. We could be dealing with moms that are weeks away from delivery or even months. So keep that in mind as we're talking about some of these complications and problems. Celopelvic disproportion occurs when the head of the fetus is larger than the pelvic opening. This makes vaginal delivery very, very difficult, and quite honestly, it may be completely impossible. With these, a cesarean usually is required for delivery. Before attempting a delivery in the field, ask the patient if there's a history or suspicion of a cephalopelvic disproportion issue. Asking them if there's any known issues or complications sometimes will bring this up, but realize it may not even be known. If this is present, it can lead to a massive hemorrhage and some other serious postpartum complications. So if you have one of these where the baby just has a very large head and you have delivery, you should always suspect that there could be a lot of hemorrhaging after the baby is born, as well as some other postpartum complications that may come along with that, and be prepared for that and be prepared to adjust and adapt to that. So let's talk about some complications that may happen during delivery, before or during delivery, and then we'll talk about some complications, some post-delivery complications as well. So sometimes we'll have something that's a cephalic presentation. This is where the newborn's head is overly extended, leading to the face or parts of the face actually presenting first in the birth canal. This is relatively rare, but it can occur in certain situations, such as if the baby is premature, or the baby is abnormally large. The cephalopelvic disproportion can also affect this as well. So a couple of those things that we just talked about can lead to this more cephalic kind of presentation. these things can kind of present themselves in a couple of different ways. You may have a brow presentation. This is where the head is only slightly extended, where we're starting to see, instead of the crown of the head, we're starting to see a little bit more of the brow or a little more of the forehead. We could have an occipital posterior presentation where the baby is face up, which may cause a more difficult labor because the babies typically come out face down. When they come out face up, it's going to cause a few more problems because it's really hard for the turning, for the shoulders to turn. And then we have the military presentation where the head is in a neutral position, either flexed or fully extended. So it's either fully flexed or fully extended position, making that delivery much more important. If the newborn's head cannot be externally rotated into position or the normal delivery can't be completed, support the mom and baby as best you can. Keep them in a stable and a comfortable position and provide rapid transport to a facility that can handle these complicated deliveries, and ensure that all the necessary interventions are available for both the mother and the newborn. As a medic in the back, you're going to have your hands full, so having an extra hand or two is going to be helpful in these situations, while your partner's driving you to the hospital. Breech presentations occur when a different part of the body other than the head leads the way through the birth canal. There's different types of breech presentations that we can have. We can have a frank breech. This is where the hips are flexed and the knees are extended, with the buttocks as the presenting part. So the legs are going to kind of go up, and you're going to have a cheek presentation. You're going to have a couple of cheeks kind of peeking at you. With incomplete breech, this is where one or both hips and knees are extended, and this is where we'll have one or both feet presenting out first. And then we can have a complete breech. This is where both hips and knees are flexed, with the buttocks as the presenting part as well. If the buttocks are presenting and delivery is imminent, position the mom with her buttocks on the edge of the bed or the stretcher with her legs flexed up towards her chest. Allow the newborn's buttocks and trunks to deliver spontaneously. Don't pull on the baby. Once the legs are clear, support the newborn's body. Lower the newborn slightly so that it hangs downward by its own weight just a little bit. Once the hairline is spotted, grasp the newborn's ankles and lift the baby upward towards the baby's abdomen, and this should help facilitate the baby's head being born. Realize that the head and shoulders are the two largest parts of the baby, so mom's getting tired towards the end of the birthing process, so sometimes the head is a little more difficult to deliver. By lowering the baby but keeping them supported and then raising them once you see the hairline, that will help the baby's head to be delivered in those breeches. If the head doesn't deliver within 3 minutes, the newborn may suffocate. You'll need to place a gloved hand in there and with your palm facing the newborn's face, and provide a V with your 2 fingers on either side of the newborn's mouth and nose to push the vaginal wall out of the way so that the baby can get air. Do not forcibly pull the newborn out or allow it to explosively deliver. If the head does not deliver in 3 minutes, provide a breathing route for the baby and rapid transport with the mom's hips elevated on some pillows. Of course, try your best and do everything you can to maintain that airway through transport. Again, this is one of those complicated deliveries where having an extra hand or two in the back of the truck is going to be very, very helpful while you're transporting. Footling breech is when one or both feet show through the vaginal opening, and a transverse presentation is the fetus lies crossways in the uterus, and we see a hand or a hand may be protruding out. In abnormal presentations, do not attempt delivery in the field, and we need to make sure that we're providing rapid transport. And that's going to be if we have one presenting limb, whether that's an arm or a leg, we're not going to be able to deliver that in the field, and we need to get moving to a facility that can, do a C-section. Shoulder dystocia is when there is a difficulty in delivering the shoulders of the newborn. Factors that'll increase this is diabetic women, large babies, and of course post-term pregnancies where the babies actually get to grow a little bit bigger. This occurs after the head is delivered, but the shoulders can't pass through the symphysis pubis. If the shoulders can't clear the birth canal, the fetus can't breathe because the lungs are still inside the birth canal and being collapsed. The cord is actually being compressed and the fetus is not receiving nutrients from the mom. A major concern for the newborn is brachial nerve plexus damage, so nerve damage to the brachial plexus in the shoulder. So what we need to do is something called the Roberts maneuver. It's one of the safest maneuvers used to kind of help widen the pelvis and reposition the fetus at the same time. So have the mom hyperflex her legs tight up to the abdomen. So bend her knees and legs and get them all the way up to her abdomen. And you may need someone to help assist with doing this. It helps if she can grab her knees and pull her legs up close. May be necessary to apply a little bit of pressure to the lower abdomen and gently, and I mean very gently, kind of pull and manipulate the baby's head to see if it will kind of get the shoulders to clear and to begin to come out. We talked a little bit about this, was mentioned in an earlier section of this chapter, but the nuchal cord is when the umbilical cord becomes wrapped around the newborn's neck during delivery. The cord compression during labor may cause the fetal heart rate to slow, leading to fetal distress. This rarely results in death, but it's one of the first things to check for when the head is delivered. So we're always going to look for this nuchal cord issue. When we find this, we're just going to slip the fingers under the cord and gently attempt to slip it over the fetus's head and shoulders. If unsuccessfully, we're going to have to carefully place a couple of umbilical clamps 2 inches apart and cut the cord between the clamps, so that way the cord is out of the way and it's not going to restrict delivery or cause us some other issues or tear. Prolapsed umbilical cord is where the cord emerges before the fetus does. It becomes compromised when the bony pelvis and the presenting part of the baby begins to move through the birth canal. This compression shuts off the oxygenated blood supply from the placenta to the baby, and it can lead to fetal asphyxia if circulation is not quickly reestablished and maintained. Rapid treatment for this is imperative. So what we want to do is keep the mom supine with her hips elevated to reduce the pressure on the umbilical cord. 100% oxygen to improve fetal oxygenation, and then have the mom pant with each contraction to prevent her from bearing down. We do not want to have a delivery. Using 2 fingers and of a gloved hand, gently push the presenting part back up into the canal until it no longer compresses the cord, and then drive like a maniac. Continue to maintain gentle pressure on the presenting part, trying to keep it far in the birth canal as you can. Carefully cover any exposed umbilical cord with dry, sterile dressings that have been moistened sterile dressings with normal saline to protect it from drying out and furthering injury. Keep the patient in this position and sustain pressure on that presenting part throughout rapid transport to the hospital to minimize further cord compression and to maximize fetal oxygenation. All right, so here's some postpartum complications that we may run into. There's a uterine inversion, and what happens is when the placenta doesn't detach properly, it winds up pulling the uterus inside out during expulsion. This is usually caused by improper handling of the 3rd stage of labor. The severity is going to depend on how far the uterus has inverted. In an incomplete inversion, the uterus is turned inward but is not visible outside the body. However, with a complete inversion, the uterus is fully turned inside out and may be visible externally. In a prolapse inversion, the top of the uterus or the fundus protrudes through the vaginal opening, and in a total inversion, both the uterus and the vagina are turned completely inside out. This condition is extremely painful and can lead to rapid hypovolemic shock. So what the management for this is going to include, we're going to keep the patient lying flat, 100% oxygen, 2 IVs of normal saline, and of course do not attempt to remove the placenta if it's still attached to the uterus. We're going to leave that kind of stuff alone. Carefully monitor vital signs for shock. Consider administering some oxytocin if your protocols are going to allow that. This will help with managing the hemorrhaging. You can make one attempt to replace the uterus. Using the fingertips and palm of a gloved hand, gently push the uterine fundus up and back through the vaginal canal. If unsuccessful, cover all protruding tissues with moist sterile dressings and transport rapidly to the nearest facility. It's normal for the mom to lose 150 mils or so, a little under a half a pint of blood during the delivery process. But postpartum hemorrhage is when the blood loss exceeds a pint of blood, or about 500 mils, within the first 24 hours. This can actually happen early on or late on. Early postpartum hemorrhage usually occurs 24 hours after the birth, and it's the most common type. Late postpartum hemorrhage happens between 24 hours and up to 6 weeks after delivery. So it is possible for us to be called on a late postpartum hemorrhage after somebody's been released and been at home for some time. And that's why they always send the mom after delivering that 6-week window of no lifting and doing all of those types of things where they're on restrictions. Postpartum hemorrhage can happen when the uterus doesn't contract properly after the placenta has been delivered. Several factors can interfere with this, including lacerations around the vaginal opening and the perineum that can cause additional bleeding, prolonged labor or delivering multiple babies, which can exhaust the uterus, retained placental tissue, so the placenta doesn't completely detach, which prevents the full uterine contractions from taking place, or when the uterine actually loses its ability to contract, is another issue that can happen with that. And then if there's this grand multiparity where there's repeated pregnancies, repeated muscle and non-contracting fibers, the repeated pregnancies actually replace the muscle with non-contracting fibrous tissue within their uterus. Multiple pregnancies can overstretch the uterus and weaken future contractions. And of course, placenta previa affects the muscle contractions in the lower part of the uterus. So also a full bladder, which can actually interfere with placental separation and uterine contractions as well. So the way that we're going to manage postpartum hemorrhage in the field is by continuing to do that uterine massage, massaging the fundus of the uterus and encouraging the woman to breastfeed shortly after delivery, which can help stimulate uterine contractions by naturally releasing Pitocin in the body. If your protocol allows it, you may need to add some Pitocin to, say, add 1,000 milliliters to an IV bag, or add Pitocin to a 1,000 milliliter IV bag, and then and run that at the specified rate. Notify the receiving facility of the patient's condition and estimated time of arrival, and begin immediate treatment. Of course, you're going to need a couple of large bore IVs to run some saline in en route. Avoid internal vaginal exams, because we don't ever do those, and never pack dressings into the vagina either. Manage any external bleeding from the perineal tears by applying firm pressure, and place ice packs in that area as well to kind of help, cause a little vasoconstriction and hopefully help slow that bleeding process and get some clotting going on. So pulmonary embolisms are not unusual in the postpartum moms. It's one of the leading causes of maternal deaths during childbirth and in the postpartum phase. Common causes are going to be, of course, as we've mentioned, amniotic embolisms, where fluid leaks into the maternal circulation. And then, of course, we're going to have some pregnancy-related venous thromboembolisms that are often due to a clot from deep vein thrombosis, usually in the lower extremities. Lastly, we could have a water embolism, which occurs when water or air enters after birth, enters the vaginal opening and gets into those areas where the vessels are open after a water birth delivery. Suspect a pulmonary embolism if the mom in the postpartum state shows signs like sudden shortness of breath, sudden and really unexplained shortness of breath, tachycardia, atrial fib, hypotension, sharp or sudden pain in their chest, and syncope. Signs might be mistaken for shock, are going to include those things like increased heart rate, tachypnea, and hypotension. But be careful in thinking that it's just purely simply a shock issue. Management's going to be same for any kind of pulmonary embolism, even in a non-pregnant patient. Recognize and be aware of the condition, administer high flow O2 and rapid transport. There's nothing we're going to be able to do for this in the field. We've got to get them to a facility that can manage them. Postpartum depression. About 1 in 9 women experience postpartum depression in one way or another. Symptoms can appear at any time during pregnancy and up to a year afterwards. Risk factors that are going to increase the likelihood of postpartum depression are typically seen as, if there's a history of depression, maybe there's some financial or relationship issues, if they have a history of diabetes, if it was a complicated pregnancy, major life changes, struggles with infertility, and multiple pregnancies. Signs and symptoms are going to include typical depression signs such as loss of interest in self-care, difficulty sleeping or sleeping excessively, overwhelming sadness or frequent crying, lack of appetite, maybe even anger directed at the infant or a lack of interest in the infant, and then of course in worst cases thoughts of harming themselves or the infant. Postpartum depression is a serious condition and it does require professional treatment, which cannot be provided in the pre-hospital setting, so these patients need to go to the hospital. Okay, we're going to round this out. This is the last section, and there's 10 or 12 slides left, so hang in there. We'll get through the trauma in pregnancy and the issues that we might see with that. Trauma is a big-time complicating factor in pregnancy. It is the leading cause of non-obstetric maternal death in the United States. And of course, the major of these causes are going to include, as you would expect, vehicle crashes, but falls actually make number 2 on the list, followed by domestic abuse, penetrating injuries, and pathophysiology and assessment considerations for these is going to be, we want to make sure, we want to try to rule out and kind of determine what that mechanism of injury is. Typically the mechanisms are similar when these occur. So once we've done that, realize that the effects on the mom are going to be very similar to the non-pregnant mom or the non-pregnant person. So the trauma effects are going to be similar, but there's some other considerations to take into account here when we have a pregnant mom. Realize that those anatomical changes that the pregnant moms go through are very important considerations when we're dealing with trauma. Remember, the abdominal contents can compress into and up into the abdomen. The diaphragm is going to elevate by about 1.5 inches. So chest trauma is associated with a much higher incidence of abdominal injuries as well. So remember, the peritoneum actually stretches to its maximum amount that it possibly can. So those abdominal issues are going to be further complicated by the fact that you have a baby taking up a lot of space and the peritoneum is actually stretched to its limit, and there's little room for respiratory wise for recovery and those kinds of things. In the first trimester, the uterus is usually well protected by the bony pelvis and is rarely damaged in trauma. However, in the second and third trimesters, the uterus begins to extend well into the abdomen, making it much more vulnerable to trauma. So in motor vehicle crashes, the lap belt may actually compress the uterus while the shoulder restraints is going to reduce the chance of uterine injury. Penetrating wounds, though, a large uterus actually protects organs that can lead to better outcomes, but the fetus often doesn't turn out well in those situations. When you examine the patient, you may see abdominal tenderness, abnormal fetal positioning, and easily palpable. It's easy to feel the baby, but there may be an inability to palpate the top of the uterus, and there may be extensive vaginal bleeding. The bladder is at the highest risk of injury with these patients as early as the second trimester due to its displacement upward and forward, so it puts it in a much more vulnerable position. So take note of the seatbelt placement on the restrained pregnant patients in a motor vehicle crash and look for bruising that may indicate that there could be bladder involvement. As the uterus enlarges, it becomes much more vulnerable to injury. So those deceleration forces are going to cause things like uterine rupture or abruptio placentae in these patients. Pregnant patients may exhibit different signs or responses to trauma as well. Tachycardia may be harder to interpret due to the normal increased vascular volume during pregnancy. Expanded blood volume can mask early signs of hypovolemia, but a falling blood pressure may not be noticeable until as much as 40% of the blood volume is lost. So this is why it's important to aggressively manage pregnant patients if the mechanism of injury suggests that there is a potential for shock. So we need to be prepared for that. Blood volume redistribution in the pelvic region increases the risk of bleeding to death in cases of pelvic fractures because there's just more room down there for that blood to hide. A respiratory rate below 20 breaths per minute is inefficient due to the increased oxygen demand of the pregnant mom. If artificial ventilation is necessary, administer supplemental oxygen at a higher minute volume rate than usual. There is also a greater risk of aspiration due to the slower digestive process in a pregnant mom and the reduced bowel motility, so there's more likely that she may actually still have some stomach contents lingering around that can lead to aspiration. Considerations for the fetus in trauma. Fetal injury can result from rapid deceleration, impaired fetal circulation. If the pregnant woman experiences massive bleeding, her body will prioritize itself over that of the baby, and it will begin to shunt away blood from the baby to maintain maternal homeostasis. Fetal heart rate is the best indicator for fetal status after trauma. A normal fetal heart rate is going to range from between 120 and 160. A rate lower than 120 is going to indicate fetal distress, which is a dire emergency in a trauma situation. Manage for the patient, for the traumatic OB patient, you'll only be able to treat mom directly. There's nothing we're going to be able to do for the unborn baby. By treating mom, we give the baby the best chance of survival. So we want to determine the gestational age of the baby if possible. The injury potential for the baby generally cannot be assessed in the field. But a decreased fetal heart rate will be a big indicator of a true emergency. Normal fetal heart rate is not a guarantee, though, that the fetus is not in any danger. So we need to realize that significant injuries to mom are likely to result in significant injuries to the baby, or even abdominal injuries that may not be severe to mom may be more serious to the baby. Pre-hospital management of the mom with abdominal trauma is the same as that for the non-pregnant patients. Of course, ABCs are going to take priority. Transport the pregnant mom on her left side if there's no concern over spinal injuries. If the mom must be transported in the supine position, be sure to elevate the right hip about 6 inches, or you can turn the long spine board to the left a little bit, elevate that right side. The fetus may not be getting enough circulation even if the mom's vital signs appear to be normal, so keep that in mind. Initiate early and aggressive fluid resuscitation for those indications that may that are likely to lead to shock. Field treatment of a pregnant trauma patient is going to include keeping a good airway, regulation, keeping an eye out for regurgitation and aspiration in these patients. If the patient is unresponsive, make sure that we get a good airway management control by placing an endotracheal tube, and provide carotid pressure until the airway is secure. So these patients, oftentimes it is helpful to do a little bit of cricoid pressure, do that Selleck's maneuver to try to get that in place. Of course, using a bougie is probably going to be the best, most effective way to ensure that you get that airway on the first attempt. 100%, or administer oxygen at 100%, because their oxygen needs are going to be 10 to 20% higher than a normal person. So if they're unresponsive, 100% oxygen, be a non-rebreather. Assist ventilations where needed. And then remember to provide a higher than usual minute volume respiratory rate for these patients because of that higher oxygen demand that they have. Ventilation is going to be more difficult because the uterus is actually putting a little bit more pressure, upward pressure on the diaphragm. Once the patient is intubated, a positive pressure ventilator is helpful to ensure visible chest rise. These can be really, really helpful. Control external bleeding and splint any fractures as you normally would. Start 1 or 2 IVs of normal saline. Use large bore catheters if possible. And of course, administer a bolus of fluids to maintain blood pressure as needed. Larger fluid volume is going to be needed for these patients because remember, they're not going to show signs of volume loss until they've lost a considerable amount. Be sure to notify the receiving facility of the patient's status and your estimated time of arrival. And of course, you're going to transport that patient as left laterally recumbent as you possibly can, giving their particular situation. In the instances of maternal cardiac arrest, we're going to perform the manual left uterine displacement procedure during resuscitation. Early delivery may actually improve both maternal and fetal survival rates if they're past 20 weeks of gestation, but we may not have a say in that. Ideally, if they deliver early, it might improve survival, but that doesn't necessarily mean that that's going to happen. The exact timing at which the periterm cesarean delivery should take place is unknown. Preparations should be initiated if ROSC has not been obtained after 5 minutes of adequate resuscitation effort. So what we're saying is if we don't get ROSC in the first 5 minutes of resuscitation, we need to be thinking about separating mother and baby, in some way, shape, or form, which means we need to get them transported somewhere where that can happen. Paramedics should try to ensure the best chances of survival by transporting the patient, activating that high-risk obstetric, anesthetic, neonatal resuscitation teams. So we're going to have to transport them to a facility that has these things available. However, it may be necessary that this maybe needed to be done if they're in cardiac arrest, maybe need to be done in the nearest emergency room where the physician can do an emergency cesarean. Providing high quality BLS and ACLS, and then of course understand the local resources and the EMS system protocols is really going to be essential when dealing with these types of patients. So realize too that normal landmarks that we use for chest compressions may be a little bit more difficult to find in the 3rd trimester. So we want to use that sternal notch as a guide for our hand placement. Pregnant women are most susceptible to vomiting and aspiration during resuscitation. And I know I've mentioned that probably no less than 4 or 5 times in this chapter. So that's something that you need to make sure you make note of and realize that this is a real concern. Monitor for emesis and maintain an open and patent airway. When necessary, make sure you can secure that airway in the most secure way as possible. There is a mnemonic. Of course, there's a mnemonic for everything, but there is a mnemonic that we can use to help identify the reversible causes of cardiac arrest in a pregnant woman. It is a little bit different for pregnant women. So there is a mnemonic for that. Of course, airway, we want to get a good airway, provide good breathing. This mnemonic is A, B, C, D, E, F, G, H. So we added a couple there on the end. So airway, we're going to secure a good airway, make sure it's clean and open. Breathing, provide breathing and ventilatory support as needed. Good chest compressions for circulation. Defibrillate when needed. Look for those reversible causes, all those H's and T's, and especially like hemorrhage, embolism, and trauma things. Fluid resuscitation. Then consider the gestational age. This is going to be consider early delivery. This is for those with no return of spontaneous circulation after 5 minutes. This is kind of that whole gestate where we need to be thinking about getting to somewhere that can separate mom and baby. And then if the H is going to be that high risk obstetric team activation. So we want to activate the system that is going to give mom and baby the best chance of survival. And when it comes right down to it, unfortunately, when we have to choose, oftentimes, the baby is sacrificed for the survival of the mom, depending on the gestational age of the baby. So that, ladies and gentlemen, is the end of chapter 42. I almost forgot what chapter we were on. So that's the end of chapter 42 and the end of obstetrics. The next chapter is going to be chapter 43, and we're going to talk about that little bitty thing that was just born in this chapter, and we're going to talk about neonates and all of those types of things, and then we'll get on into pediatrics in the chapter after that. All right, so see everybody back at chapter 43.